From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine, Montefiore Medical Center, and JAMA Neurology web editor. Today we are talking about drug-drug interactions, more specifically, anticoagulants and anti-seizure medications. Joining me today is Dr. Allison Willis, who's here to discuss her and her colleagues' work entitled Direct-Acting Oral Anticoagulants and Anti-Seizure Medications for Atrial Fibrillation and Epilepsy and Risk of Thromboembolic Events. Dr. Willis is an Associate Professor of Neurology and Epidemiology at the University of Pennsylvania School of Medicine. She is a core faculty member in the Center for Real-World Effectiveness and Safety of Therapeutics. She's the chief of the Division of Neurology at the Philadelphia VA Center, as well as Associate Director for the Center for Health Equity Research and Promotion. Dr. Willis, thank you for joining myself and our listeners. Welcome to the podcast.
Thank you, Dr. Armand. It is my pleasure to be here with you today.
So, atrial fibrillation and epilepsy. Can you tell our listeners about the relationship between these two diagnoses?
So when we think about atrial fibrillation and epilepsy, our first thought might be that they are fairly separate and not connected at all. But if you've cared for patients with one or the other, you can begin to see some links. Patients with atrial fibrillation are at increased risk of cardioembolic or thrombotic strokes. That is the reason that we anticoagulate them or offer them anticoagulant therapy. Those strokes or the scarring from those strokes, whether they are clinically significant or not, can later serve as a nidus for a seizure or cause focal epilepsy or cause a seizure disorder. So that's one way that atrial fibrillation can increase your risk of a later diagnosis of epilepsy. And then another way to think about how they are connected is that both atrial fibrillation and having seizures increases the risk of falling or losing consciousness or falling from a standing or sitting height. And so if you have a patient who has epilepsy and they also are anticoagulated for the reason of atrial fibrillation, one must be really careful about making sure that their epilepsy is very well controlled, because a fall could put them at risk of injury and bleeding from the anticoagulation. The two conditions have causal links, but they also have safety concerns and clinical considerations that we have to keep in mind when we're caring for patients with both disorders.
One of those safety concerns and clinical considerations is basically the medications that we use when we're treating these patients. What are the common anti-seizure medicines that you find are more often culprits of being wary of drug-to-drug interactions? For our listeners who are very early on in their career, medical students, residents, let us know what you come across on a day-to-day basis, especially in pharmacoepidemiology and your research.
It's important to think not only about medications that we are exposed to or we use often for seizure control in the United States. It's important to think about anti-epileptic drugs and anticoagulants on a large scale when you're considering drug-drug interactions. The most common medications that are worrisome for causing drug-drug interactions that are used for the treatment of epilepsy are also the medications that are most easily available and most widely used across the globe. And they are phenytoin and carbamazepine and valproate. These are also the medications that can cause interactions with a lot of medications, including anticoagulants.
I'm sure not even for epilepsy alone, but a lot of these medications are used for other neurologic conditions. And so this comes up very often in our clinics and hospitals. Tell us about the inspiration behind your study. Where did that come from, and what is your hypothesis, what you're hoping to get out of this current research?
This paper is part of a body of work coming out of the pharmacoepidemiology and neuroepidemiology research cores at the University of Pennsylvania that is focused on the medication exposome. The exposome is a concept that scientists have been thinking about on many levels, from the macro level to the micro level, and we are focused on the medication exposome. And that work is focused on understanding how pharmaceutical compounds that we're exposed to, whether through prescribing or through supplements or over-the-counter drugs, can influence our disease state, our disease symptoms, our health, and our outcomes. This particular paper was seeking to understand whether and the extent to which the potential drug-drug interaction between enzyme-inducing anti-seizure medications and direct-acting oral anticoagulants was clinically relevant. So there had been some data in vitro that suggested that enzyme-inducing anti-seizure medications could, through the enzyme induction, make DOACs, or direct-acting oral anticoagulants, less effective. That would be problematic for a person requiring a DOAC to prevent against stroke and to treat or prevent against recurrent venous thromboembolism or pulmonary embolism. And yet there wasn't real-world evidence on that potential interaction. It was limited to in vitro data, so potential data. Well, it's unethical to create a randomized control trial that could potentially place patients at risk. And so we did an observational study using the most advanced pharmacoepidemiology methods available to understand, using real-world data, whether there is an observable, clinically relevant interaction between those groups of medications.
As a practicing neurologist, looking at the drug-drug interactions, deciding what to give a patient, I mean, you got to err on the side of caution, and you may not want to give them something that's notoriously enzyme-inducing to increase the risk of further venous thromboembolism or what have you. What do you think the risk is out there with these medications?
As practicing physicians, we should first do no harm. And our hypothesis was that there would be a clinically relevant interaction between enzyme-inducing anti-seizure medications and DOACs that resulted in an increased incidence of clinically diagnosed venous thromboembolism or stroke or other thrombotic events.
Right. I would think so as well. Tell us about your study design.
Our study design used some of the state-of-the-art methods that are recommended for pharmacoepidemiology research. First, we required that everyone in our study sample be a new user of an anti-seizure medication and direct-acting oral anticoagulant. That's really important because if you are examining study outcomes in patients who have been taking a medication for a long time, then what you are really observing is outcomes in the subgroup of patients who were able to tolerate the medication, benefited from the medication, were able to afford the medication, and not studying outcomes in patients who stopped a medication early on after initiating it for reasons that you can't observe and control for. So we required that everyone be a new user of an enzyme-inducing anti-seizure medication and a direct-acting oral anticoagulant. Another really important methodological feature of this study is that we had an active comparator design. And Dr. Armand, that gets at a key clinical question that we have when caring for patients with neurological conditions, which is, when I am faced with several choices, what are the safest alternatives? What is the safest choice for this patient? It also avoids comparing users versus non-users. And I want to emphasize that as a methodological point because we should not be comparing users of a medication to non-users of a medication. It simply isn't an acceptable method at this point. So this was a new user active comparator design. And the active comparators were people who were taking non-enzyme inducing ASMs and DOACs. So you had people taking DOACs for atrial fibrillation. Some were taking enzyme inducing ASMs. Some were taking non-enzyme inducing ASMs.
And these are ASMs, anti-seizure medications.
Yes.
Now, your study population, where did you pull that population from? And do you feel that the study data was representative of the general population?
There are lots of choices for pharmacoepidemiology research, and there are several data sets that can be available. We chose a data set from the Optum de-identified Cliniformatics data mart. It is a data set that has been made available to researchers by our institution. It is a large health insurance network that has been shown to be population representative of adults in the United States. It does not include a large number of individuals with traditional Medicare. However, our results shouldn't be extrapolated to the older adult population with traditional Medicare. However, it can be viewed as reasonably representative of the privately insured population in the United States.
Well, on that note, tell us about your results.
So our results suggested that when comparing the outcome of thromboembolic event, which was our primary outcome, between individuals who were taking an enzyme-inducing anti-seizure medication and a DOAC versus persons who were taking a non-enzyme-inducing anti-seizure medication plus a DOAC, there was not a statistically significant difference in thromboembolic events. So our secondary outcome was a major bleeding event. And we found that there was a slightly lower and statistically significant risk of a major bleeding event in persons who were taking an enzyme-inducing ASM as compared to those taking a non-enzyme-inducing ASM. It's pretty exciting.
What do you make of that in terms of clinical practice?
Whenever I think about the results of a study like this as a pharmacoepidemiologist and as a practicing neurologist, I always ask myself, number one, what will I do when the results are replicated and there is some consistency in the evidence? In the meantime, our results provide some clarity on the safety of using enzyme-inducing ASM and DOACs for people who have epilepsy as the reason for their ASM and atrial fibrillation as the reason for their DOAC. And I think that's really good news because there is limited access in most of the world to other anti-seizure medications beyond the enzyme-inducing ASMs, and we know them to be quite effective for the control of epilepsy. Our secondary analysis and the interpretation of our secondary finding of a moderate reduction in the risk of major bleeding events associated with enzyme-inducing ASMs compared with non-enzyme-inducing ASMs tells us that there is still some potential drug-drug interaction that is occurring. So one way to interpret that secondary outcome is that it could be enzyme-inducing ASMs are interacting with DOACs to a degree that the risk of bleeding is lowered, but without a clinically significant increase in the risk of clotting. I don't think this initial evidence has reached the level and consistency that is required with replication and other data sets for me as a practicing neurologist to then go and switch a person from a non-enzyme-inducing ASM to an enzyme-inducing ASM for the specific purpose of lowering bleeding risk. But it does tell us that there is potential for clinically significant drug-drug interactions in this case, and that we need to explore this further.
Based off of this study, I think I feel a little, okay, I'm going to continue my practice. And for my patients who don't have a choice on medications because of insurance purposes, costs, things of that sort, I may not feel as though they're getting the short end of the stick, for example. And so I think that's an important point to make here. These medications are effective and these results reassure me in a sense. But obviously, absolutely, there's more research to be done on this topic.
I agree, Dr. Armand. I would view these results as reassuring and also as preliminary. I would not, based on these data, change someone to a enzyme-inducing ASM for the purpose of protecting them from a major bleed, nor would I change a person from an enzyme-inducing ASM to a non-enzyme-inducing ASM out of concern that there is an increased risk of thromboembolic event. So in short, I really view work like this as helping us understand how the medication exposome can enhance our patient care. It can help us reduce drug reactions, and it can support efforts to improve overall health outcomes.
Thank you so much for this research of you and your colleagues. I'm looking forward to future studies that further solidify this and find a bit more that we may not necessarily know about these classes of medications. Dr. Willis, thank you so much for joining us today.
Thank you, Dr. Armand, for having me. I would like to thank my co-authors and my colleagues in the Center for Real-World Effectiveness and Safety of Therapeutics in the Department of Biostatistics, Epidemiology, and Informatics, and in the Department of Neurology at the University of Pennsylvania.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This is Dr. Cynthia Armand. Thanks for listening.